Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a soft cataract. Let us observe this surgery. We can see the pupil is not well dilated. The patient is a 75 years old man and the patient had floppy iris in the other eye. So this is a case of floppy iris syndrome with soft cataract, and this is a very challenging situation. By this time the main incision and two side ports have been made, and now my plan is to stain the capsule with trypan blue dye. I don't want to use a pupil expansion device in this case. Pupil expanders usually disengage in such cases. Better option is iris hooks in floppy iris syndromes, particularly when there is LIDRS, lens iris diaphragm retropulsion syndrome. In those cases, the pupil suddenly becomes large as soon as the phaco handpiece goes into the eye with irrigation on and the pupil expansion device is disengaged. The capsule has been stained with trypan blue dye, and this is viscomydriasis, injecting a lot of visco to dilate the pupil, and the pupil has dilated to about 5.5 to 6 millimeter. And I am doing rhexis with the help of a Utreta forceps. The capsule has been punctured by the Utreta itself, a tag has been raised, and a rhexis is being completed. The capsule goes along the border of the pupil to get an adequate sized rhexis. Size of this rhexis is about 5.5 millimeter or 5.75 millimeter. Now hydro dissection. See what happens as soon as I try to do hydro. As soon as I try to do hydro, equator from 3 o'clock to 7 o'clock prolapses out of the capsular bag, and I don't try to push it again into the capsular bag. My plan is to manage this nucleus in this tilted position. Here it is. I go with the phaco handpiece into the anterior chamber, bevel down, then I turn the handpiece, make the bevel sideways, and hold the tilted nucleus. The chopper goes on the other side and I divide the nucleus, and I emulsify a portion which is above the anterior capsular rim, but I don't come near the endothelium. I remain, the tip of the phaco needle remains at the iris plane, and with the help of the chopper I try to tilt the nucleus a little more, and I divided the nucleus, and now a large portion of the nucleus is still in the capsular bag. The pupil has become small. I am afraid of catching the iris with the phaco needle. Vacuum is 300 in this case, flow rate is 30, and ultrasonic energy is 40%. Now most of the nucleus has come out. This small part of nucleus, it is dangerous if I try to hold this nucleus with the phaco needle. So at this time I decide to come out, inject some visco behind this nuclear base. So I have come out, take some SPMC, inject some HPMC in the anterior chamber, and a large portion of the HPMC is behind the nuclear piece, that is in the capsular bag. And now I take a blunt instrument, an iris spatula, go behind this nuclear piece and lift it off. Yes. And now I am in a very safe position. There is a lot of visco in the capsular bag, and the nuclear piece is almost in the anterior chamber. A part of it in the anterior chamber tented up, and a part is in the just behind the anterior capsular rim. And here it is, with very low vacuum of about 200. This nuclear piece is emulsified, and here I find that most of the cortex also has come out. I tried to remove some cortex, but there was no cortex, so I injected visco and implanted an intraocular lens. This is the hydrophobic acrylic single piece monofocal intraocular lens from Appasamy Associates. There is a yellow tinge in the optic of this intraocular lens. A Sinskey hook goes through the side port, and the trailing haptic is placed in the capsular bag. I rotate the lens. Anticapsular rim is seen only at 2 o'clock. I bring the other haptic to this, the haptic optic junction, and I check that it is behind the anticapsular rim, so the whole lens, whole intraocular lens is in the capsular bag. And now at this time I want to check if there is any cortex anywhere. So I inject some visco and ask for an instrument which is shaped like an eye, and I can retract the iris all around, and I find that there is no cortex anywhere. So in this case, the hydrodissection was such that all the cortex came out. All the cortex was in the nuclear epinuclear mass. And now this is cleaning of visco, cleaning of the capsular bag, cleaning of the anterior chamber angle. A thorough cleaning of visco is done. First irrigation, and then irrigation and aspiration is used. So in this case we have seen actually lens tilt technique, where we tilt the nucleus, emulsify the supracapsular portion of the nucleus. We can crush the rest of the nucleus between two instruments, the phaco needle and the chopper, and manage the. In this case, the people are so small that I had to be extra cautious not to catch the iris. Dear colleagues, when we are ready to accept challenges, challenges are fun. We enjoy the challenges. When we know that our skills are very much sound, we can overcome any challenge, then challenges are fun. We actually welcome challenges. Wish not it were easier. Wish you were better. Don't wish for less problems. Wish for more skills. Don't wish for less challenges. Wish for more wisdom. Always remember this quote of Mr. Jim Rohn. We must continuously strive to uplift our skills. we should be able to do any cataract, whether it is hard nucleus or small pupil, whatever it is. And we must adopt different techniques. It's not good that I do only phaco. I don't do small incision cataract surgery or ECC. There are cases where ECC or small incision cataract surgery or large incision cataract surgery or double SICS, all these techniques are better in some cases than phacoemulsification. So always master different techniques and always uplift your skills to another level. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Hope it will inspire you to continuously strive to reach to another levels of surgical skills.